This is Agnes, the presenter of Sickle Cell Talks with Agnes. Welcome to my YouTube channel. So stay tuned because every week we'll be posting videos about any topic in sickle cell disease. We don't have set days yet, but just turn on the post notifications for you to be notified every time we post a video. Thank you and stay tuned. If you've got any questions, get in touch with me on social media or social media platforms. Thank you.
Sickle cell disease has been something that I got interested in because I went to medical school in the West Indies, and while there, I got to see sickle cell disease as it looks in a developing country, and I got to see physicians treating sickle cell disease without the resources to treat it, and then I got to come here in the United States where I got to see sickle cell disease patients being treated in a high resource setting with no compassion. Very different from the experience that I saw in the West Indies. And that was very striking to me. And that got me involved in this space. Now, I'm not gonna talk too much about all of that. We have quite a bit of information to cover today because the therapeutic landscape, thankfully, for sickle cell disease is exploding. It's evolving quickly, and there's a lot of information to keep up on, keep track of. And my efforts on social media have been geared actually towards my patients, because 30 minutes, 20 minutes, 30 minutes with a patient in the clinic is not enough to go over conceptual basics of sickle cell disease pathology, physiology, and to talk about the way new drugs work. So I was finding that if I spent the appropriate amount of time, I would run out of time with my patient. So now I made a podcast, I made an Instagram, I made a Twitter. So if I want to start a patient on a new therapy, I tell them, hey, why don't you go listen to my podcast, episode number 5. This is the therapy I'm thinking of starting, and tell me what you think once you listen to it. Then they get an hour of information. Anyways, we'll give you guys a high level sort of view of what's happening in the therapeutic landscape of sickle cell disease. Here are my disclosures. So we'll briefly talk about sickle cell disease, and then we'll talk about Endari, Adakveo, OxBrighter. It says overview of gene therapy here, but for purposes of this talk, I'm going to exclude gene therapy at this moment. So of course, we all understand why this is such an important topic. We all understand that for the last 30 years, we have only had hydroxyurea in the toolbox for physicians that are taking care of sickle cell disease. And of course, as great as hydroxyurea is, sometimes when the only tool you have is a hammer, every problem looks like a nail. There are a significant amount of patients with sickle cell disease that are not candidates for hydroxyurea simply because of the genotype they have. That's the first thing. The second thing is there are a lot of medical and social issues associated with hydroxyurea that all of us are very well aware of, that sometimes make it not practical for patients to be taking hydroxyurea, even when they are candidates to do so. So we've been waiting for a long time to have the ability to walk into a clinic room and say, here are your options for therapy. Let's talk about your options and why each one is different, what are the pros and cons. This has been a long time coming. So the story from 1910 to 2020 is a very interesting one. Of course, in 1910, Walter Clement Knoll is described as the first American patient with sickle cell disease by James Herrick. And then we get a better understanding around how sickle cell disease happens, what the mutation is, by people like Lemuel Diggs and Linus Pauling and Vernon Ingram. Of course, right here in Detroit, Dr. Charles Whitten starts talking about the psychosocial issues involved with sickle cell disease and how this is a biopsychosocial disease. The Black Panthers, sort of civil rights activist group, funds the first sickle cell disease screening in the United States in the 1970s, and the National Sickle Cell Disease Act is passed. Of course, in the 1980s, we have the PROPS study that looked at penicillin prophylaxis to prevent infection in individuals with sickle cell disease in the 1980s. Of course, hydroxyurea shows itself around the 90s after animal studies in the 80s. Then we see Endari almost 20 years later, followed by Adakveo, and then voxelotor in the November to Remember, as it's been called. So this is where we are right now. But it has taken us a very long time, and it has been a very hard path to this point in time. And of course, sickle cell disease is two stories, right? As Agnes sort of pointed out, it's a story of 5% and 95%. So we are fortunate in the United States and Australia to be part of that 5%. But really, this is a story of that 95% who might never see this new therapeutic landscape. And I think it's always important to keep that frame of reference in mind, that while we take care of our 5% right now, the end goal is that the entire population of sickle cell disease, the 5% population and that 95% population, both get treated, both get to the finish line with equity and equality along with this evolving therapeutic landscape. And we always talk about sickle cell disease as sort of an umbrella term. So of course, when we say sickle cell anemia, we're talking about hemoglobin SS or hemoglobin S beta 0. But when we say sickle cell disease, we're also including other compound heterozygote phenotypes like hemoglobin SC, S beta plus, SO, SD. So this differentiation will become important because, as you all know, hydroxyurea is indicated at the age of 9 months in people with sickle cell anemia. That's SS and S beta 0. So now we're suddenly in a therapeutic landscape where these other compound heterozygote types will be able to access new medications. And as you all know, as a quick review, this is an autosomal recessive disease. That means that both parents must pass on a gene to their child. And in the case where there are 2 parents that have trait, you have a 25% chance of having an affected child. So of course, the spirit of the red blood cell is such that it is completely dependent on its ability to be deformable and maintain its disc shape. And inside of each red blood cell is a molecule called hemoglobin. And that molecule is so important, it's quite literally the reason why we breathe, to load hemoglobin with oxygen. What we see in sickle cell disease is that a defective beta globin gene introduces sort of a sticky pocket within hemoglobin. And the exposure of that sticky pocket only comes when oxygen is not attached to hemoglobin. And what we see then is that these hemoglobin pieces start sticking together, forming these long, sort of rigid strings that alter the shape of the red blood cell and alter the spirit of the red blood cell. And of course, within each individual red blood cell, there are trillions of hemoglobin molecules. So in the body, you have as much hemoglobin as you do grains of sand on every beach on planet Earth. And with that being said, of course, a disease that affects hemoglobin will have multiple manifestations, which we have all seen. So let's go through this in sort of a little bit of a pictorial fashion. I like pictures better than words. So we have red blood cells. When oxygen comes off of them, their shape changes, they sickle. And what we see is damage to the blood vessels surrounding it, oxidative damage. And the result of that then being the generation of what we call sticky proteins, or like Velcro almost on the blood vessels. And this is, usually by proteins called selectins. And then we see this activation of the immune system, particularly neutrophils. And then of course that traffic jam at the end of it that we're all so familiar with, right? The traffic jam of vaso-occlusion that results in pain and organ damage and stroke and all of the manifestations of sickle cell disease, both acute and chronic. And of course, the acute complications are the things that keep patients in touch with the hospital, but it's the chronic complications that keep physicians like me awake at night thinking about my patients, right? It's the chronic complications that result in mortality that's 30 years less in a sort of expected survival that's 30 years less than non-sickle patients. So the management of sickle cell disease is complicated, right? It's a multi-system condition that's characterized by acute and chronic complications. Early diagnosis has definitely improved life expectancy, but the quality of life we still find deteriorates. And there are psychosocial reasons for that on top of the biologic reasons for that. And those psychosocial reasons are very underappreciated. So today we're going to be talking about the biologic sort of changes we can make, but the psychosocial issues we need to still keep in mind. The anxiety, the anxiety associated with when is my next pain crisis coming, the PTSD associated with that really bad pain crisis that lands you in a hospital with a physician or a nurse that doesn't believe you, right? These types of psychosocial issues really change the way your disease plays out over your life. So even with the best care possible, life expectancy compared to the normal population can still be reduced by almost 30 years. And we have the bottom line is we have failed the adult sickle cell population. We have seen a tremendous decrease in the deaths of children with sickle cell disease, but as time has gone on, actually, the amount of deaths we're seeing with adults with sickle cell disease has increased. So we definitely, at least in the United States, have a huge problem with adult care for sickle cell disease. I'll be curious to hear what's happening in Australia from that standpoint. So there's two ways we can classify treatments. We can classify them as treatments that help and treatments that cure. For the purposes of this talk, we'll be talking about treatments that help. So let's start with blood transfusion. So blood transfusion, of course, is based in the concept that if I decrease the number of sickle cells by putting in normal red blood cells, I can decrease the amount of endothelial injury, the amount of damage that's happening. And the situation in which blood transfusions are used most is in the setting of stroke, both stroke prevention and stroke treatment, right? So we have two types of stroke prevention, primary and secondary. When we talk about primary stroke, we're talking about reducing the chance of a first stroke. And this is usually happening in people who have had their transcranial Doppler that shows that they might be at high risk for stroke. These patients are put on blood transfusions. Then, of course, secondary stroke means you've had a stroke and we're trying to prevent the next one, because once you've had a stroke, you're higher risk for a second stroke. And those patients with secondary prevention by blood transfusion are basically on lifelong blood transfusions from that point. Of course, it's not that simple, right? Blood transfusions are associated with adverse events too. We definitely are infusing patients with lots of iron with every blood transfusion that goes in. The body doesn't have a good way to remove that iron, so patients are required to take chelation therapy to remove that iron. Of course, with every blood transfusion you get, because the blood is not coming from someone who's identical to you, there's a chance that you have a reaction or develop an antibody to the blood that's being given to you. So we call that alloimmunization, which in the United States, at least at my center, we have about a 25% chance, 25% incidence of alloimmunization or antibodies to blood. So blood transfusions come with some pros and cons, but of course, when patients are sick, when patients are really spinning out of control into the wrong direction in the hospital, we use blood transfusions frequently, be it for stroke, acute chest syndrome, splenic sequestration, many of the sort of acute issues that you guys are familiar with. All right, let's talk about the old standard, hydroxyurea. So hydroxyurea is the old standard. It's the old standard. It's the flag bearer of sickle cell therapeutics for a good reason, right? We have vast experience with hydroxyurea. We have a medication here originally not designed for sickle cell disease, but one that is supremely effective in sickle cell disease and works in a variety of ways, not only by increasing fetal hemoglobin that you guys are so familiar with, but also by reducing the number of sickle cells in the body, by reducing the white blood cell count in the body in effort to reduce that traffic jam that we call vaso-occlusion. There's of course 30 years worth of evidence looking at the safety of this medication that makes physicians so comfortable with hydroxyurea's use, so much so that it's a conversation that we have with every parent and try to initiate in every child at 9 months of age with SS or S beta 0, regardless of the severity of their disease. And why are we so comfortable with this? Why do we push this? Well, the evidence comes really from two studies. The MSH study in 1995, where a study of adults showed that, so basically when you look at the number of events that are happening here, the lower you are on the curve, the lower the curve is, the less events that have happened. So what we see is when you look at patients who are on placebo versus hydroxyurea, on the left side here in adults, you see there was a reduction in the number of events of pain that they had when they were on hydroxyurea. And of course, when we look at kids with Dr. Winfred Wang's study out of St. Jude, 2011, the baby hug study, we call it, we see a decrease in acute chest syndrome in hydroxyurea patients. We see a decrease in pain in hydroxyurea patients. We see a decrease in dactylitis, swelling of the hands and fingers in hydroxyurea, in the fingers of the hands and feet. We see that in the hydroxyurea patients, and we see a reduction in transfusion need in the hydroxyurea patients. This has led to, of course, our stance on hydroxyurea. So when we talk about the new therapies, I want you to keep in mind that this is not necessarily a hydroxyurea or new therapy conversation. Every therapy we talk about is a hydroxyurea and conversation. The preferred situation is that we have a patient who's benefiting from multiple drugs to really amplify their survival and amplify their organ protection. And here, at least in the United States, we have a huge problem with hydroxyurea adherence. My prescription writing rate is probably 90% for the hydroxyurea eligible patients. Of the patients who take it, it's probably 20%, 25% in that range. I hope that in Australia, you guys have a better sort of success outcome, but we have many sort of medical and social reasons behind this, right? So patients sometimes, they drop their counts with hydroxyurea. They have side effects, abdominal pain, hair thinning, skin changes, right? That makes it not tolerable for them. But of course, there's social issues. Why does my nurse put on a glove before she administers hydroxyurea to me? It's going into my body. Can I get pregnant? Is this going to change my sperm count, right? All issues that come up over and over again with hydroxyurea. So there are definitely some issues associated with its use, and our discussions around hydroxyurea have not been, as providers, effective. So let's jump into the first drug, Endari. So Endari is basically L-glutamine. L-glutamine is a conditionally essential amino acid. That means in times of stress, it becomes low. And when red blood cells were studied, particularly in sickle cell patients, it was found that sickle red blood cells take up L-glutamine at almost triple or 4 times the rate as compared to normal red blood cells. And this is really interesting because L-glutamine results in the creation of something called NAD. And NAD is very important, and you might have heard this term, oxidative stress. NAD, or antioxidants, right? So NAD is basically antioxidants. It builds this antioxidant pathway within the body. So the thought was, if we give patients L-glutamine, they make this NAD, NADH, they supplement this system within their body, and they're able to have their own antioxidants. And what was found in a study of 230 patients that took this medication, broken up into 2 groups, again, placebo and patients who got L-glutamine, of which 2/3 of the patients were on hydroxyurea. It was found that with or without hydroxyurea, L-glutamine was associated with fewer acute pain episodes, fewer hospitalizations, fewer days in the hospital, and fewer acute chest syndrome incidents. And again, this is that same type of graph showing cumulative numbers of pain crisis on the left, showing that L-glutamine patients on the L-glutamine arm had a reduction in the number of pain crises. And then what we see on the right side here is time to the first crisis and time to the second crisis. And we see there's a big difference in basically the amount of time it took for patients to report a first crisis when they were on the clinical trial, and then their second crisis. So L-glutamine showed that it delayed the onset of pain. No significant adverse events reported in the trial. One advantage is that there's no therapeutic drug monitoring required here. There's no checking of levels. There's no checking of CBCs. There's nothing like this. The mild adverse effects that were noted were low-grade nausea, non-cardiac chest pain, fatigue, and musculoskeletal pain. Long-term efficacy at this point is unknown, and ongoing studies will report on that. And again, one thing that's very interesting is, though the mechanism that I discussed is theoretical, we really don't have confirmation on the mechanism of action for this drug. All right, let's talk about OxBrighter. So OxBrighter, or voxelotor, is a new oral agent made by a company called Global Blood Therapeutics. And remember, when we go back to sort of this picture here, we talked about the shape of red blood cells being circular and it being dependent on the oxygen coming off of hemoglobin for the shape to change into the sickle shape. Now remember, that's because the hemoglobin S polymer can only be made in states where oxygen has come off of hemoglobin. So Global Blood Therapeutics said, okay, what if we make a medication that allows hemoglobin to hold on to oxygen just a little bit more tightly? What if we keep oxygen on hemoglobin, thereby never allowing the hemoglobin molecule to become sticky and not allowing that hemoglobin molecule to stick to itself and make that polymer, not allowing the sickle cell to form, not allowing for the red blood cell to break open. So they said, we're going to do that. And we're going to say our medication is successful if we can increase hemoglobin by 1 gram. And the reason for that was because we have a huge body of evidence that suggests that patients who are more anemic, have more severe disease, are more likely to die, are more likely to have chronic organ damage. Patients who have hemolysis, which is the breaking open of red blood cells, tend to also progress to organ damage and death faster. So what we see in this waterfall plot is in the patients that were treated with the approved dose of voxelotor, almost 60% of them had a hemoglobin response. And we're seeing patients that are hitting 1, 1.5, 2, 3, 4, almost 4 grams of hemoglobin increase on this treatment arm, compared to a 9% response in the placebo arm. So quite an impressive increase in hemoglobin in patients that are being treated. So you may say to me, Dr. Z, 1 gram of hemoglobin, what difference does that make to me? And I'll tell you, 1 gram of hemoglobin for a sickle cell patient is the equivalent of 1 bag of blood. 1 gram of hemoglobin might be the difference between an extra hour or 2 of activity, an extra 500 or 1,000 steps, right? The answer is we don't really know functionally what that means. But what I can tell you is that in the patients that I have treated so far, in my experience here in Detroit, we have had a tremendous experience in not only hemoglobin increase, but reduction in things like the jaundice that patients are having. The number one thing I hear from patients I've started on this medication is, Dr. Z, the yellow in my eyes is gone. And I never realized how important that was to my adolescent and teen population. And that's pushing them to keep taking this medication, because as we decrease the amount of red blood cells breaking open, we reduce the amount of bilirubin, the amount of jaundice, right? So there's clearly an increase in hemoglobin, a decrease in hemolysis. We think, of course, all of this is pending confirmation. We think that this is going to benefit sickle cell disease patients from progressing to organ damage and progressing to death. There were some adverse events, most commonly headache and diarrhea. The most significant adverse event was hypersensitivity or allergic reaction to the medication. But beyond that, really, this seems to be quite a safe drug. Finally, we'll talk about crizanlizumab, which is also known in America as Adakveo, which is a medication built for pain. Of course, the reason that sickle cell patients interact with the healthcare system the most is related to pain. So certainly we need a medication that can help us reduce the amount of pain that requires hospital admissions. With crizanlizumab, what we're talking about here is what I like to call a Velcro inhibitor. Remember, I told you that as blood vessels progressively get more and more damaged, we start seeing this sort of expression of Velcro almost onto blood vessels that allows red blood cells and white blood cells to stick to them, driving that traffic jam of vaso-occlusion. What we have in crizanlizumab is an antibody that binds to that Velcro, that allows it not to bind to other white blood cells and red blood cells and not allow that traffic jam to form. So the way that this medication is given as a once-a-month IV infusion, actually for the first 2 doses, it's 2 weeks apart, and then it's once a month. This drug was approved based on these data that I'm presenting to you today. So looking at high dose, which was the dose that was approved. And I don't know if you can see my mouse. Let me just try to pull that up here for you guys. Okay, can you see my mouse? Yeah, okay, good. So the high dose crizanlizumab arm, we see that compared to placebo, which had a pain crisis per year rate of 3, we see the crizanlizumab approved dose arm had a crisis per year of 1.6. And very interestingly, we actually see there are patients in this arm of the study that had no pain, period. So quite a difference, almost a 50% drop in pain. And we see when we break down patients by how many crises they had, so I would say moderate versus severe, we see huge reductions. So if you look at patients who had 5 to 10 crises in the year before they were given crizanlizumab, you see on average they had this median rate of 5 pain episodes down to 1.97, right? So quite an impressive decrease in pain. Again, time to the first sickle cell crisis, time to the second sickle cell crisis increased by a huge amount of time. Adverse events in this group included arthralgia, which is just pain in the joints, sort of, diarrhea, pruritus or itching, vomiting, and chest pain. This happened in at least 10% of patients. The drug, in my experience, has remained safe for my patients. We have infused this patient on at least, we have infused this drug on at least a dozen patients with no issues and a tremendous reduction in their pain profile. So again, combination therapy, this is a hydroxyurea and discussion. Hopefully we can start combining new therapies as we learn more and more about their safety. And we're pushing for combination therapy to be approved here in the United States. And hopefully you'll see some of this in Australia sometime soon. So we truly are on the next frontier in sickle cell therapy. There are almost 20 drugs still in the pipeline that are coming for sickle cell disease. So this is a historic time. And the way that we behave in this sort of next 5 to 10 years is going to change the way we tell the story of sickle cell disease for the next 50 to 100 years. So we really are in an unprecedented era. It's an era that will allow us to correct the historic marginalization of patients who have been subject to inferior outcomes, unfortunately, at least in the United States, mostly due to their race. There has been no new therapy for sickle cell disease in at least 20 years. Thankfully, we now have a new conversation to have with patients. We have a huge problem with sickle cell providers. There certainly are not enough sickle cell providers in the United States, particularly for our adult patients. And this might be contributing to the reason why our adult patients are dying. But I remain hopeful that as we provide new tools to providers for their sickle cell warriors, we may see that providers become more enthusiastic and more motivated to take care of sickle cell disease. With that being said, there's always more to learn. For me, I have given my patients sort of this resource. This is my podcast. It's called Cheat Codes Sickle Cell Podcast, where we talk about new therapies, old therapies, all of the new scientific literature. We break it down in a patient-friendly way to really allow patients to sort of grasp onto some of these very solid concepts that are required in their understanding of sickle cell disease physiology, because at the end of the day, the best weapon you have against sickle cell disease is knowledge about sickle cell disease. And as long as you have that knowledge of sickle cell disease, it's very difficult for physicians, nurses, things like that, the healthcare system at large to treat you poorly. So I urge you to follow Dr. Z Sickle Cell on Twitter, Instagram. Please subscribe to the podcast. That is all I have for you today, Agnes. I hope that that was helpful to the patients who are listening, and I appreciate you giving me this platform to interact with our Australian warriors.